Welcome back to the ProPA podcast. I'm your host, Prof G, and you're listening to another episode of our MSK101 series, where we walk through high-yield musculoskeletal and rheumatologic conditions one topic at a time, all straight from the PANCE blueprint. In today's episode, we're talking about Henoch-Schönlein Purpura, now more accurately called IgA vasculitis. This small vessel vasculitis that affects kids more than adults has a classic tetrad of symptoms you'll want to know cold for your exam. Let's dive in. Did you know that HSP is the most common vasculitis in children? It usually follows a respiratory infection and can mimic other conditions, which is why the classic rash is such a crucial clue. So first, before we get into that, let's do some kinder patho. So what is HSP or IgA vasculitis? Well, it's a small vessel vasculitis caused by immune complex deposition, specifically IgA. This leads to inflammation in the skin, the GI tract, the kidneys, and the joints. It's most commonly seen in children aged 3 to 15, often after an upper respiratory infection. The exact trigger is unclear, but the immune system reacts abnormally, leading to systemic inflammation of the small vessels. HSP has a classic tetrad of symptoms. First, palpable purpura. This is a non blanching rash, which is usually on the lower extremities and the buttocks. Number two in the tetrad is arthritis or arthralgias. This is commonly seen in the knees and the ankles. Three on that tetrad is abdominal pain. These patients tend to get colicky abdominal pain, sometimes with vomiting or even GI bleeding. And four in the tetrad is renal involvement. You're going to often see hematuria and proteinuria, ranging from mild to nephritic syndrome. Other possible symptoms include a low grade fever, scrotal pain or swelling, and edema in the hands and the feet. So, how do we work up these patients? Well, it's primarily a clinical diagnosis. Supportive findings include an elevated serum IgA, an elevated ESR or CRP, hematuria and or proteinuria on urinalysis, and normal platelet count. This distinguishes it from other causes of purpura like ITP. If the diagnosis is unclear or atypical, a skin biopsy can show IgA deposition in the small vessels. So, what does the treatment look like? Well, most cases are self limited and resolve within 4 weeks. Treatment is mostly supportive. So, we want to give hydration and encourage rest. We can give some NSAIDs for the joint pain if the kidneys aren't affected. We can also consider corticosteroids, and these may be used in severe cases, especially with GI or renal involvement. Patients with significant renal involvement may need a referral to a nephrologist. All right, so quick book med versus street med. Book med, classic rash on the legs, joint pain, belly pain, and blood in the urine. This is going to be your textbook case. On the street, ch- on the street, kids may present with vague belly pain or limping before the rash even shows up. If the rash is faint or missed, this can be mistaken for appendicitis or even abuse. Always think of HSP when you see unexplained abdominal pain plus a rash plus joint symptoms in a child. All right, some quick clinical pearls. So, most common pediatric vasculitis that we're going to see, we're going to look for that palpable purpura. This is the dead giveaway. And GI and kidney involvement determine its severity. Remember, this typically follows a recent URI and it is self limited, but we want to monitor for renal complications. All right, now it's time to test our knowledge. So, question one, a 7-year-old boy presents with a rash on his legs, mild knee pain, and abdominal pain. His urinalysis reveals hematuria. Which of the following is the most likely diagnosis? Is it A, rheumatic fever, B, Henoch-Schönlein Purpura, C, systemic lupus erythematosus, or D, immune thrombocytopenic purpura? Well, this one shouldn't be too tough. We've been covering it this entire time. It is HSP or IgA vasculitis. The answer was B. This is a classic presentation of HSP with palpable purpura, arthralgia, abdominal pain, and renal involvement. Question 2. What is the most appropriate initial treatment for a child with HSP and mild joint pain? Is it A, high dose corticosteroids, B, methotrexate, C, supportive care with NSAIDs, or D, intravenous immunoglobulin? I'll give you a few seconds. If you said C, supportive care with NSAIDs, you are right. So, most cases of HSP are self limited, and NSAIDs can be used for joint pain if there is no renal impairment that is present. So, some final thoughts. HSP is one of those can't miss pediatric diagnoses, and the good news is it usually resolves on its own. Just remember the tetrad: rash, joint pain, abdominal pain, and hematuria. And always check the urine, even if the patient seems well. If you found this episode helpful, go ahead and follow the ProPA podcast and tap the bell so you never miss a high yield episode. Want visuals to go along with these audio breakdowns? Head over to my YouTube channel, Professor GPAC. Thanks for tuning in to today's MSK101 Clinical Medicine Brief on HSP. And remember, this is the ProPA podcast, where future pros in medicine are made. I'll catch you soon.